But. There is always a but. But there is a time for everything. There is a time to laugh and a time to cry, a time to rejoice and a time to suffer, a time to breathe spontaneously and a time to breathe mechanically. And the point is that we should know when it is better to breathe mechanically rather than spontaneously. That is, sometimes mechanical ventilation is good. It's not always bad. First of all, it saves lives. But then it might alter the progression of ARDS. It might be a form of therapy of ARDS. And in some ways, I will try to show you that that has at least some truth. We all know that in the initial early phase of severe ARDS, neuromuscular blocking agents improve survival. The mechanism by which they do that is not entirely clear, but this is a fact. Cisatracurium saves lives. Second, we believe, at least I believed, that spontaneous breathing would reduce the risk of ventilator-induced lung injury. At the opposite, it might increase it, particularly in assisted breathing. Because if we have 30 centimeters of water airway pressure, and we inflate a lung in the form of a balloon, the transpulmonary pressure will be 30. If we have 30 centimeters water pressure in the airways and we make minus 10 in the chest because we pull out the chest with our muscles, now the transpulmonary pressure is 40 centimeters of water in spite of the same airway pressure. So if you are not careful, you might increase the risk of ventilator-induced lung injury unless you decrease the airway pressure. Because, in a way, the patient is damaging himself. He is making 10 centimeters negative water pressure that increases transpulmonary pressure. Well, it's the job that usually muscles do. But in certain conditions, I will show that this is dangerous. If we indeed, we measured the transpulmonary pressure in patients being ventilated by pressure support at various levels of pressure support and compared that with controlled mechanical ventilation. We obviously measured the airway pressure, esophageal pressure, the transpulmonary pressure we computed, and then the flow. And we did that in 10 different patients with esophageal catheters at 3 levels of pressure support and compared it with controlled mechanical ventilation. And we were looking for the same tidal volume. As expected, when the tidal volume was the same, the transpulmonary pressure was the same. And it is obvious because the transpulmonary pressure is the one that causes the tidal volume. So no matter whether your patient is breathing spontaneously or mechanically, if his tidal volume is 500 milliliters, his transpulmonary pressure has one value, the same value, be it being ventilated mechanically or be spontaneously breathing. What is important is the tidal volume. And we see often particularly in the early phases of ARDS or during weaning, that some patients breathe tidal volumes around 1 liter. It's not exceptional. Is that good for them? I don't know. I will not choke them because they're breathing too much, but I don't know whether this is good. But even more dangerous than that is the problem of alveolar pressure. Alveolar pressure we can compute if we know airway resistances, because transpulmonary pressure is between the mouth, or better the tube, and the thorax. But this is not the real pressure that the lung sees. The pressure that the lung sees is the difference between the pressure in the alveoli and the chest. So let's compute the alveolar pressure. If I have 20 centimeters of water in the airways and I inspire, as an example in pressure support, the pressure in the alveolus must be lower than the pressure in the airways, otherwise the flow will not move. To get air moving from the airway from the tube to the alveolus, the pressure in the alveolus should be lower. And that is caused by the airway resistance. The higher the flow, the higher the airway resistance, the lower the alveolar pressure. And this is the mechanism by which we can generate pulmonary edema or even ARDS in experimental models. We know that if we add resistance to the airways of an animal and let him breathe, it can induce lung injury and ARDS. Here you see a patient going from pressure support 2, almost CPAP, to controlled mechanical ventilation. And you will notice that during very low pressure support, almost CPAP, the alveolar pressure during inspiration drops well below end expiratory pressure. And the higher the pressure support, the lower the drop. The higher the inspiratory flow, the higher the drop in alveolar pressure. The main difference between controlled mechanical ventilation and spontaneous breathing is alveolar pressure. During controlled mechanical ventilation, alveolar pressure is always, both during inspiration and expiration, higher than end expiratory pressure. During spontaneous breathing, the alveolar pressure drops below end expiratory pressure during inspiration. It must. Otherwise, air will not move from the tube to the alveolus. My friends tell me, well, but that is recovered during expiration. But during expiration is passive, both during spontaneous and controlled mechanical ventilation, with a few exceptions. So in general, the pressure that the alveoli do see for 50% of the respiratory cycle is lower than what you think, because it's lower than PEEP. You can put 10 of PEEP, but the alveoli of your patient will see a lower pressure during inspiration. And we know, at least Norman Staub says that, it's a rather strong reference, that the interstitial pressure and the pressure around the capillaries strictly follows the alveolar pressure. So you will have a lower than expected pressure in the interstitium of the lung. I suppose draining fluid from the vessels to the interstitium. Here, Dr. Yoshida showed us that if you have moderate lung injury and you have the rabbit breathing spontaneously, it might improve. But if you have severe lung injury and you make the animal breathe spontaneously, his respiratory drive will be very high, and at the end it will be worse than controlled mechanical ventilation. That is, when I have a patient with capillary leak in a surgical ward, he does not yet have ARDS, just have leaks in his capillaries. Then he breathes very strongly, he has a very high drive, his respiratory rate goes up. During the inspiration, the alveolar pressure drops down, and he gets a whiteout of the lung. Then you come, put a tube, connect him to mechanical ventilator. And as a matter of fact, the same might happen with asthma. This is another, very light reference, New England Journal of Medicine, 1977. You might believe that in ARDS the problem is very minor because ARDS is very different from asthma. We do not have increased resistance. Wrong. Very wrong. In ARDS, the lung is not stiff, is small, and you are ventilating just a quarter or a fifth of the normal lung. It means the airway resistance are 5 times higher, because one lung has double the airway resistance of 2 lungs, and a quarter of a lung has 4 times the airway resistance of the entire lung. And we measure the airway resistance in the ARDS, and you can see that the airway resistance goes hand in hand with end expiratory lung volume, that is the size of the baby lung. We do mistakes sometimes, like here, we went from controlled mechanical ventilation to spontaneous breathing too early, and you see the result. The chest X-ray becomes more white. In my mind, that's increased pulmonary edema, caused by this very strong inspiratory effort. This is a patient in ECMO, and we tried to, you read papers of patients breathing spontaneously in ECMO. They don't tell you when do they put in spontaneous breathing. Probably not the first day, but because in the early phase, you see here the esophageal pressure, and this swing is 35 centimeters of water. Very dangerous in my mind. What else? Oh, yes. So we have a vicious cycle in ARDS. We have at least in the common model of ARDS, the one that refers to increased permeability. We have an injury that increases the permeability of the lung. We have capillary leak, and then an initial interstitial lung edema. That causes by itself a slight impairment in gas exchange, nothing dramatic, but a big increase in respiratory drive. Your patient initially is very tachypnoic, PCO2 is 28, PO2 is not bad, respiratory rate is 32, he breathes like hell. And this increased respiratory rate is caused by dyspnea. The esophageal pressure goes down, the alveolar pressure goes down, minute ventilation goes up, and that is what? Ventilation-induced lung injury. And we know that hyperventilating a sick lung causes ventilation-induced lung injury, be it spontaneous or mechanical. So what is the importance of controlling the respiratory drive during the phases of spontaneous breathing of ARDS? I don't know. We have no data. All we know is that the initial phase of ARDS, if we put neuromuscular blockers, survival increases. We have experimental data showing that spontaneous breathing might be bad. So I'm not saying that spontaneous breathing is bad. I like to be spontaneously breathing. But at times, spontaneously breathing obviously might be dangerous, and you better use controlled mechanical ventilation, because mechanical ventilation is not just an aesthetic improvement of gas exchange, is also therapeutic in certain phases of ARDS. Thank you very much.
Antonio, thank you very, very much for these two talks, very exciting. Then we have 10 minutes together, both, to try to answer to the question. You convince me of that now. I have no idea about what we should do. Both you are very convincing, and the two presentations are open for discussion. Maybe waiting the discussion I start. Alain, Antonio, in fact, are you agree for some situation both when we should never use spontaneous breathing and other when you should absolutely? For example, are you agree for very severe ARDS, we should absolutely use no spontaneous breathing and put in myorelaxant, and for the late phase spontaneous breathing?
For me, it depends of the phase. At the very early phase, no doubt, we never use spontaneous breathing mode at the very early phase of ARDS. And for example, in our study in these burst trials, during the first 24 hours, all patients received a neuromuscular blocking agent. And then, after 24 hours, we stop. And I must say that in some patients, because the very big problem is the very high respiratory drive of patients with ARDS. And in some patients, when you stop the neuromuscular blocking agent, despite the very high doses of sedative, you cannot control this drive. And we have to re-inject neuromuscular blocking agent. But you must make the test. Because if you never stop the neuromuscular blocking agent, you cannot know if it is possible. So it is very important. And at this point, I am really convinced that the best way is to have a mode without any synchronization, controlled breath, and the possibility of spontaneous breath, not assisted breath, because it will result in so high tidal volume. The second part of the answer is the problem of the setting of the PEEP, and it's very important, especially in order to avoid too high level of transpulmonary capillary pressure, to have a quite high level of PEEP if you begin to use this strategy. It's very important. So it depends, of course, of the phase, of the severity of the disease, but you have to test.
Antonio?
It's called personalized medicine. Do the right thing in the right patient at the right time. So you have to find the time. How do you find the time? You measure. You measure simple things like respiratory rate, PO1. If you have an esophageal pressure, you are very rich. But you can measure the effort, and you can get a good idea from the TI-T-tot ratio. But I think those are the most simplest: rate, TI-T-tot, and PO1.
Okay.
Then you can elaborate, but...
Giuca and Giacomo?
Just one comment. I mean, if you look at the increase in cardiac output during the spontaneous breathing, could in this context also be deleterious, because you increase the flow through the pulmonary circulation and therefore also the capillary pressure. So that could even enhance the adverse effect of a negative pressure in the alveolus.
You can have two sides of this risk. You can either have a failing left ventricle or an increased blood flow because of increased work and increased pressure too. So,
yes, but
thanks.
On the other side, in the study by Christian Petersen, as you have seen, there was an increase in cardiac output with a decrease in shunt. And as you know, it is quite unusual to have, because of the shunt flow relationship, suggesting that there was a recruitment. So, okay, and I agree that the danger may be in patients with a hyperkinetic status, it may be dangerous.
Yeah, the problem is that we do not know exactly which therapeutic goal, which physiologic therapeutic goal to aim for. Initially, we were looking for good oxygenation, then recruitment, then recruitment and shunt. But we know that sometimes you have good oxygenation, but mortality increases. So there are many things we don't know still.
Giacomo?
Yes, I would like to make a comment and also hear your opinion. I don't want to overcomplicate the things, but I think it's important a remark on what is alveolar pressure, because, for example, if you take a situation in volume assist control with constant flow, and whether if the patient starts to breathe actively, the ventilator will decrease the airway pressure just to keep the flow constant. So if you look at transpulmonary pressure, basically, this is exactly the same whether the patient is breathing or not. But the consequences for the alveolar pressure and the hemodynamics will be very different, because then you suddenly start to have a negative intrathoracic pressure. Or on the contrary, you can have a situation with very high resistances. In controlled ventilation, transpulmonary pressure will be very, very high. And also in assisted ventilation, transpulmonary pressure will be again high, but the pressure surrounding the lung is very different. It's very negative in one case and it's not in the other case. So I guess my comment here is about the fact that sometimes just looking at transpulmonary pressure is not telling you the entire story.
Well, unless you are at zero flow.
I fully agree. It is, and yes, but at the bedside, for the how to deal with that? And my answer is very, very simple. The problem is the dose. We have to control the level of effort. And as you have seen in the paper from Petersen, the level of inspiratory effort we need to obtain some of the beneficial effects in terms of distribution of aeration with spontaneous breathing, this level is quite low, and we have to control. And for example, in our study, the patient in the spontaneous breathing arm, let's say, received high dose of sedative, of course, because if you decrease these doses, the efforts will be so huge, it would be impossible to prevent acute ventilator-induced lung injury induced by, or let's say, spontaneous breathing-induced lung injury, and so it is very important, the dose of effort.
Okay. We have time for one question, if you have a question. No question? Yes. Last one.
To control the respiratory effort is something really difficult. If you have a really increased respiratory effort, you cannot decrease it with sedatives. It's a clinical experience.
Done this in 250 patients, and it is possible. It is high dose, and in the study, once again, all the study by Christian Petersen, if you see the doses of sedative relatively high, and once again, just to tolerate a small, very small level. It is sometimes equal. It is why in some patients, and maybe the most severe patient, during the first 2 or 3 days, it is impossible, right? And we have to okay, but we have to test first, because it is very difficult to guess before stopping the neuromuscular blocking agent in which patient it will be possible. So we have to stop, and in some patients, half an hour later, we have to re-inject the neuromuscular blocking agent because it is impossible to control the drive. Yes, you're right.
If we would be able to control the respiratory breath, we could make awake ECMO in RDS, and this is not possible. Isn't it, Antonio? Okay,
thank you very much for this nice discussion about the two speakers. If you want to finish the discussion, you can read in the Intensive Care Medicine Journal the 3 papers, 1 pro, 1 con, and 1 maybe, which developed all this discussion about for or no. Again, thank